All right, so AKIs. How do you, now we're kind of recapping everything now, right? So how do we know someone has an AKI? Well, labs are going to tell us a lot of good information, but we got to make sure there's no obstruction. Keep it simple, right? If you got an obstruction, that's the easiest thing we can do to prevent an AKI from brewing, right? From developing, right? So that's the easiest thing to miss and to think of. Oh, they got oliguria. Let's try all kinds of tests that we can do. There's a Furosemide stress test. There's a Vasopressor challenge. There's a volume challenge, an Inotrope challenge, and you realize, oh, actually, it was just kinked. I'm sorry. All right, so you got to make sure that we have a good patent Foley catheter if we have a Foley catheter in place. And just a note, like we talked about CODIs, you're going to have someone really encourage you to take the Foleys out. But in the ICU, you need accurate I's and O's. If you have an AKI, that is good enough argument to have accurate measurement of the urine, right? We want to make sure it's not less than 0.5 per kilo over 6 to 12 hours versus more than 12 to 24. You can drop all those numbers on people, but if they don't have an AKI and they're in the ICU, there's not a good reason to have a Foley catheter. But if they need accurate I's and O's, like they have a shock process, they have a high risk for AKI, you can always argue that they need the Foley catheter. So don't have people bullying you to say that you got to take the Foley out, because there's people saying, oh, it's the same evidence of having a external catheter versus an indwelling catheter. There is no evidence. It's better to have an indwelling catheter. It's the risk of CODI is low, and it is there, and we're going to do our best, but we have to have accurate I's and O's, because that can then have more harm if you have an external catheter versus an indwelling. It's just as a note. But if you do have an indwelling catheter, make sure it's not kinked. Okay. And then hemodynamic evaluation. So do they have a low blood pressure? Do they have a fluid overload? Do they have something that's causing pre-renal failure or intrarenal failure, right? Is there a new arrhythmia? AFib with RVR can cause a drop in your cardiac output, right? Atrial kick caused about 10-20% of your cardiac output. Now they're all of a sudden AFib. They can go into renal failure from that, just that little 20%, because it could be like a heart failure patient, for instance, right? They got a new medication added in the last 24 to 48 hours. So they had a new ACE inhibitor ARB added like on the floor, or they had a new vancomycin dose, right? And there's something that caused a renal insult to look for. Intake and output is going to give you a lot of good information, right? Whether you're fluid positive or you're fluid negative, right? So either one is going to tell you that you might have oliguria, right? If you're fluid negative, it makes sense. They're hypovolemic, and that's why they're losing volume. Then we can assess that they probably might need more fluids, right? And we'll do a test. We'll do a little volume challenge to see if they get good urine output. But if they have a positive balance, so we were talking about negative balance before, they have a positive balance, their fluid overload, that can be just as much compression on the kidney, so it doesn't work, right? And we need to then not give fluids. We would have to give like a furosemide stress test, for instance, right? Or even before that, we might give like a vasopressor challenge to kind of raise the blood pressure to try to get better perfusion. And we'll talk about that a little bit more. Okay, they got a low cardiac output. We talked about in cardiac about a patient that is compensated CHF versus decompensated. A decompensated patient is really, really bad heart failure, and they can't eject enough blood, so the SNS fires off. They get cool skin, and their blood backs up in the lungs. They get a wet or crackles on auscultation, or rails on auscultation. So a cold and wet cardiac patient is always bad news, and that can be lack of flow, lack of cardiac output to the kidneys. So we're going to give them a little volume challenge? No. They're oliguric, yes, they have oliguria, but it's not because of a fluid problem. This patient probably needs to jump over like an inotrope challenge, right? If we know based on their history what's going on. Okay, and then septic shock, SIRS, that can damage the kidneys pre-renal and intrarenal. But giving more volume to someone who's already got like 3 liters of crystalloids for sepsis, another volume is not really do much, right? We got to maybe like stress the kidneys out and say, hey, I need you to like a restart. I need you to try to put out some urine, because you're going to be at risk for fluid overload and at risk for more complications. Okay, and then as we mentioned, fluid overload. So they are fluid positive or negative if they have fluid overload. They're fluid positive, right? And so we're looking at all these different things we talked about: pre-renal, intrarenal, or post-renal, right? Again, pre-renal is all about that map, right? Making sure the map is adequate, making sure we have good flow to the kidneys, good perfusion to the kidneys. And we talked about KDIGO criteria at the onset of all this AKI discussion, right? You're looking for that creatinine change, like I mentioned, like you need to have that indwelling catheter so you can see if you got, you know, a 0.5 per kilo or 0.3 per kilo, right? Because stage 3 is a lot worse than a stage 1. We looked at the mortalities at the beginning. Mortality is like 50-50 if you got a stage 3, whether they're going to make it out of the hospital or not, right? So urine output's part of that, and also creatinine elevation is part of that. All right, so the challenges I was talking about. So you had like the Furosemide stress test, you had the vasopressin stress test, or vasopressor stress test, Inotrope stress test. You had all these different tests we can do to see what's going on when someone has oliguria. So classically, you always hear someone doing a volume stress test where they give 250 cc's of saline and see, do you got urine output or not, right? So keeping track, do they have a good, you know, do they respond or not, right? So really volume challenge should be done when you know that they have hypovolemia. Like, oh, look, my intake and output is super what, negative or positive? When you give volume, it was when they're super negative, right? So you can look at their eyes and nose from admission. You can see that they have a, you know, they're like negative 2 liters. Well, shoot, let's give them fluid and see if their oliguria improves. That makes sense, right? They've been super diaphoretic, right? They've been hypoglycemic, or they've been like, you know, they've been they had a UTI for the last 3 days. They've been febrile for the last 2 days, and they have all this insensible loss and to keep track of because we don't count it. And then also they had a fever. We know that's going to increase it, and they're diaphoretic. Like I think I already said that, right? But they have all this excessive loss, so they're at risk for, you know, fluid, for hypovolemia, for fluid loss. So that makes sense to give like a 250 bolus to see if that works, right? So INO is net negative. They are in the ICU. They got aggressive diuresis. We're doing what we're supposed to do to get them down to fluid even by day 3, day 4, but then we like overdid it and we made them way too negative. That can induce hypovolemic shock in the first place, or hypovolemia at least. Okay. They got nausea, vomiting, diarrhea. They got poor intake for the last 3 days. We extubated them, sent them to the floor, and they haven't eaten for 4 days. It's like, well, shoot, they're at risk for dehydration, right? So and then now oliguric. So giving them fluid makes sense, right? And echo can help us look to see if there's some changes, like when the walls are touching completely of the heart. That means it's not full of fluid, right? So there's some other things we can assess to see if they really do have hypovolemia. Okay. If someone has new onset oliguria, like all of a sudden you come on, it's like 2 o'clock. It's like, dang, I haven't had any urine output since 7 a.m. or 8 a.m., right? And they've been in the ICU for 4 days. It's very, very uncommon for a patient in the ICU or even the hospital setting to be dehydrated, right? Those are rare. That's for someone to be dehydrated. Somebody has to be someone not paying attention for that to happen. For someone to be like, you know, again, febrile, diaphoretic for 3 days, right? Someone noticed amongst all the healthcare professionals. But in the ICU, especially, it's really rare for someone to get dehydrated. We like to give fluids everywhere, right? We have what's called fluid creep, where we have enteral nutrition, we have TKOs, we have antibiotics, we have pressors, we have, you know, GI secretion. We have all these things we are giving to the patient that can raise their volume, right? So giving 250 cc's to an ICU patient doesn't make a lot of sense, right? Is it going to harm them 250? Not really, but if you keep doing it, because oftentimes you'll discover it, the next day it'll be someone new and another provider. They'll try 250 and someone else will try 250 at night, and then eventually now you're like positive 1.2 liters, right? So the idea is, you know, unless you have like a hemorrhage, like a massive hemorrhage, like, oh shoot, that's why they're hypovolemic, right? Massive GI losses. They had C-dip diarrhea for the last 5 days, right? And they had like 400 cc's, 600 cc's every day. Yeah, they're hypovolemic, right? That makes sense, right? But and of course, negative eyes, or I'll keep track of the eyes and O's. Those are trained down to negative. Then yes, 250 cc's volume, perfectly fine, right? 250 of NS, not okay, but 250 of isotonic crystalloids, great, good idea. Okay, so really volume challenges are good for like ED, right? Or you really know they had some fluid loss of some sort. Okay, and then vasopressor challenge. Why would you need to start vasopressors? So obviously after fluids, right? You realize, oh, they're CHF and they're positive 4 liters. I don't think giving fluids is going to help. So vasopressors might be the next step, but we actually have what's called a Furosemide stress test that we'll do in that situation. What we do for vasopressor challenges is they have a history of hypertension, right? When someone has hypertension, their vessels go from something like this to something like this that is all scarred over because of all the donuts that the hypertension is doing inside the blood vessels, right? All the hypertension is causing all this problem. and it's caused those vessels to get very, very narrowed, including the kidneys, including the brain, including the heart. So it's more appropriate to have a higher pressure for these patients, right? Not like a pressure of like 190. We look at MAP targets, right? So a MAP of about 75 is good for these patients. So if we be keeping them at like a 65 the last couple of days, and they were like really, really lethargic and tired and really fatigued, it's because they're not getting the blood flow to their muscles, to their brain, et cetera, right? So having a MAP of 75 would be more appropriate for those patients. So starting a vasopressor would be appropriate for these guys. Okay, so if oliguria improves, it was the hypertension that caused this. And then inotropes, we kind of spelled that picture out as well. You got someone that is in cardiogenic shock, right? Who's in cardiogenic shock? Someone that has what kind of physical exam? Someone has an exam that shows they are what? Wet, right? So they have a, what is it? They have a fluid status that is are they overloaded? Maybe. They're maybe hypervolemic all over, but all that fluid kind of maybe pushed out to the extremities with edema. But they have a exam where they have crackles or rails on exam, right? So they have crackles on exam, and then since they're not pushing blood out to the periphery, they're going to have what kind of temperature of skin? Cool skin, right? So cool, clammy skin, and they have a wet lungs. That's someone who's in cardiogenic shock or failure, right? So they say, oh, my patient's in failure right now. They have in a poor output state, right? And these patients need some support. They need to have some inotropic support. It's called an inotropic challenge, right? We're giving some kind of inotrope that's going to increase cardiac contractility. And you have to be aware that there is two varieties of inotropes. There's inotropes that dilate all the vessels and increase contractility, and there's ones that increase contractility but vasoconstrict. So you have to think, well, if someone's in heart failure, do I want to vasoconstrict? Well, actually, norepinephrine is our first line for those ones. But the ones if they have a good blood pressure, MAP is 85, MAP is 75, but they have like a poor output state, starting an inodilator would be perfectly fine, right? Dobutamine or Milrinone. Notice dopamine's not on this list, or it is there, but put that in parentheses, right? It's not one that's going to help the situation. But dobutamine and Milrinone is for good blood pressure. Blood pressure is poor. Then we can start epinephrine or norepinephrine. Those are the ones that are going to be an inopressor. They're going to vasopress, raise the blood pressure, and they're also going to increase contractility. Okay, if the oliguria improves, that means they responded to it. That worked out. So we got to figure out what the reason is for their cardiogenic shock. Do they have a new MI? Is there something going on that's making their heart failing? Yes.
What would be an indicator for a patient to be on both norepinephrine and dobutamine? Because they kind of seem like they would contraindicate each other.
Good. So yeah, norepinephrine and dobutamine have opposite actions, right? Someone can argue at high doses of dobutamine, like more than 15 mics, it then starts vasoconstricting. But for dobutamine, usually what our purposes are for 2 mic, 2.5, 5, 7.5 mics is for inodilation, right? So why would they be on both? They're just trying to. Hopefully they both work, but really what you need is a Swan-Ganz or PA catheter to assess, am I doing too much vasoconstriction? Then I need to come down the norepi. Am I doing too much vasodilation? Then I need to come down on the dobutamine. If they're great, then leave it as is, right? But if the cardiac index is low, I should go up on the dobutamine, but then my SVR might go down, then I could go up on the Levophed. So that's where you can actually cook in the kitchen and know what you're doing. It's not incorrect. They're going to try it because we have experience. We know that we're going to start dobutamine. The blood pressure will go down a little bit, so let's support a Levophed. So you can be on both, but really when you start getting patients who starts failing more, you're like shooting in the dark. You don't know which one to go up on or down on because you can cause more harm. If you go too high in Levophed, that's going to put too much stress on the heart and it can fail. And then you need more inotropy. So you need to, and ironically, if you go higher than norepi, you have more inotropy too. But you cause more vasoconstriction, it puts more stress on the heart. It's a whole thing you have to try to stop the downward spiral at some point, right? But yeah, that's like cardiogenic shock and how we have to fix that with these medications to know which one to do it, how to fix it. And the way to know is with a PA catheter. Okay. Yes.
So then in your practice, or what would you do if you notice a new onset oliguria? Most of our orders are just keep above 75. Would you just go up on vasopressors and just skip the whole volume challenge to begin with?
So it's the history. So if they're hypotensive, it's like, is there something that's making them hypotensive? Like, is it volume related? If it's volume, they're not. They're here for C. diff, right? Someone calls you and there's like, you call the provider and they say, hey, my patient has been oliguric, and then you go to that room and there's a huge isolation cart and it's like C. diff colitis. Your next question is like, how much output has there been, right? So if they've had like 1,200 cc's in the last 2.5 days. That's the reason. So giving volume is not going to be harmful, right? But and then of course they have like a GI bleed. That makes sense too, right? In that case, we could probably give blood versus 250, right? Because blood is 300 cc's. So it's just based on what the history is. That's what's going to tell you which challenge to do. If they're fluid overload, though, and we know that based on the I's and O's, like really good record keepers, all nurses are really good record keepers, and some people don't do it, unfortunately, but for the most part, it's about 80-90% accurate what the I's and O's are. You have to think about insensible losses because that's not something you count, right? About this negative 500 for each day almost is about a good ballpark. All right, but if they have that fluid, fluid gain with the I's and O's, you're giving 250 cc's is not going to help, right? Doesn't matter what disease process they have. If you're fluid positive, that doesn't help you get more fluid. In that case, we should probably give a furosemide stress test over here, where we're testing the kidneys, say, hey, I know you have a lot of volume, you have plenty of gas to work with, plenty of fuel to work with. I need you to be operational. You're trying to like jumpstart it with like lightning. I can't draw lightning good, but you're gonna have lightning. Well, that's a great lightning actually. All right, so you're gonna jumpstart the kidneys basically with furosemide or a loop diuretic. So Bumex, bumetanide, or furosemide. Those are our two go-to ones. Okay, so that's the furosemide stress test that looks at that. Is for someone who has volume to spare, and we want to try to get the kidneys flowing again, right? And if we get up to 4 mL per kilo, that means they're going to have good outcomes. If we don't get up to that much, that's actually really high risk of AKI. So you give a standard dose, and again, it's over here, about 1 per kilo, and you'll see this often as underdosed, unfortunately. That's where they'll try to get, let's just get 40 Lasix. My patient doesn't weigh 40 kilos, sir. All right, so the 40 kilos is not going to do it, right? Or 40 Lasix is not going to do it. It needs to be like 1 per kilo, right? Ideal body weight, sure, but it's usually a good hefty dose, like 100 Lasix, 80 Lasix, right? Even when you order 80, like you order more than 80, it's like, are you sure? Right, so Cerner will stop you at that point, right? And that's for someone that is furosemide naive. That means they never got a lick of furosemide like last year, right? Or it's probably hospital to say, but they haven't had furosemide for a long time. They're not at home. Then it's 1 per kilo. But if they've never, if they've never been on furosemide, then it's 1 per kilo. If they've received any kind of taste or inkling of furosemide, then it's 1.5 per kilo of Lasix, which is a lot more, right? If they weigh 100 kilos, that's 100 Lasix. If they've got Lasix before, then it's 150, right? 160 kilos. You tell your provider not to be weird and order 150 because you're doing like 3.75 of push, right?
Do you find that providers will make that order to be 1 per kilo or 1.5?
I don't see it as often as it should. It needs to be a heftier dose, and usually I'll chat with pharmacy and it says, this is the right dose, right? It should be much higher, yeah. So that's something that if you're really trying to get a good response out of the kidneys, you need to stress it. It's called a stress test for a reason. Like when you do a Dobutamine stress test for the heart, they literally give them they jumpstart the heart, and they're getting the heart rate up to like 140 to 160, right? They're stressing it. They're trying to see if there's ischemia. You're doing the same thing here. You're trying to see if the kidneys are going to restart or not. Okay, and if they have a good output, they have greater than 200 cc's or technically like 4 per kilo, then that's working. That means that the kidneys are good. We need to support them as much as possible, right? Try to look for underlying causes like we've been talking about, diagnostic tests and such. Okay, if there's not a good response, that is giving more fluids is not going to help this patient, right? They're probably fluid overload. They probably have something else going on intrarenally that we have to figure out, and that's when we invite the renal docs in to consult and see if what could be happening here. Is there something weird like a glomerulonephritis or lupus or autoimmune situation, or is it is it like a nephrotoxin? And these guys are good at it. They're going to look through all the lists and they're going to find out which one's which. And you can always pick pharmacy's brain too. Ask them, hey, are there any nephrotoxins here that we should be maybe changing? Okay, so that's the furosemide stress test that we do for patients that are not hypovolemic, basically. Okay, the other ones are for hypertension, hypertensive history, and Inotrope is with someone that's clearly in heart failure, right? So otherwise, it's either a furosemide stress test, give them Lasix and see what happens, or give them fluids and see what happens. right? And you shouldn't give fluids to someone who already has fluid overload. That doesn't make much sense. But you see it happen a lot, where because that's the fluids are still argued to this day. How much fluids you give to a patient, it's still something that's argued back and forth, right, in the literature and amongst professionals when they got trained and when they didn't get trained. So there's all kinds of variations in the practices. You're gonna see that, especially in a community hospital like this. You have different people that are coming from different areas of life. If someone's coming from like a high academic center, they're going to do this stuff. They're going to give that Lasix. They're going to ask for it. If you have someone that's been out here for 10 years, they're going to be doing just what we've been doing for 10 years. Okay, so that's why we teach you this stuff. So we give you the evidence, so you know what to do, right? So you know what is expected. Okay, so it's not a surprise when someone orders 1 per kilo, and then you're like, oh, that's way too much, right? So that should make sense, basically. All right, so treatment goals. What are our goals of these patients? So like I said, we're going to talk to pharmacy, right? That's your friend to renally adjust medications, right? They're usually on board. If anybody orders Vanco, anybody orders cefepime or Zosyn antibiotic-wise, they're going to say, oh, creatinine, I'm not going to approve that order because I just noticed the creatinine is elevated, right? Or the GFR is low. And as we'll come to find out, GFR is not exactly a great tool, right? It's a calculated value. There's all kinds of formulas to calculate a GFR, but it doesn't tell you day to day what someone's actual function is, right? And when they measured GFR, they measured it in rats or dogs or rabbits or whatever, and they measured it with someone who had no kidneys. They snip, they took the kidneys out, and they then measured what the creatinine did over time. And the creatinine will rise by 1 point when you have absolutely 0 GFR. Do our patients have 0 GFR? Maybe the really, really sick ones, but you can't predict how much fluid is going through and being made, right? And how much urine is being made. But if someone has absolutely 0 kidneys, in 1 day, your creatinine will go up 1 point. So if someone's creatinine goes from 1 to 2.2, you know the GFR is really, really bad, right? So you can't use GFR as a target, right? It's a theoretical construct, right? There's no way to assess that, oh, you have this much GFR, therefore you get this medication. You can kind of approximate that, and some of our medications are based on that, but it's really, the creatinine is really going to be the go-to element. Okay, so GFR is based on someone who has no kidneys whatsoever in a lab somewhere. And GFR is what we look at in CKD, right? So 120 plus is normal, right? It's like a clock face right here, right? So you got 6 o'clock over here, you got 9 o'clock over there. So 90 to 120 is like a stage 1 CKD technically, right? But there's more CKD stuff when you look at GFR on the outpatient side. And there we can look, they can kind of estimate how much creatinine's risen over the past 3 months, for instance. Okay, and then avoid giving potassium to patients with AKI. That makes sense, right? They can't get rid of potassium well, so if they're giving potassium supplements, those should not be in place, right? You may know that they shouldn't give potassium supplements, but the order needs to be discontinued because the next person might not know, and they may just give them because they're on autopilot or because they're super busy, and they're the patient's code, and it's like, here, get your meds, and they run to the next patient. So the idea is to make sure that we're not, putting things on the profile that shouldn't belong there, right? We have to use our critical thinking and say, let's take this off because it shouldn't be there. Same thing with like a BP target. I would say, we hold beta blocker if the systolic is less than 100. That should be on our antihypertensives, so that everybody knows that. It's like, I don't want beta blockers. Of course, I'm going to do that. I'm going to hold it less than 100. But you can't, unfortunately, you can't put your expectations on everybody else. You are you, and then you have to make sure everybody else also is going to be safe, right? It's including the patients. And then case-sparing diuretics. So we have to know our diuretics, right? And case-sparing diuretics, they are which ones? Spironolactone is one. Aldactone is the brand name for spironolactone. There's only 4 of them, right? There's actually a new aldosterone antagonist and a new MRA, which is our spironolactone and Milrinone. These are MRAs, mineralocorticoid receptor antagonists, or aldosterone antagonists. Or they're stopping aldosterone function. Aldosterone is the only hormone in the body that gets rid of potassium. So if I stop it, my potassium is going to go which direction? Go up, right? So these are potassium-sparing diuretics, right? So SEAT is the mnemonic, right? So SE are your one class medication, and AT is another class of medications or diuretics. And these 4 drugs are the ones that raise your potassium. Everything else lowers your potassium. It's as simple as that, right? So make sure they're not on these 4 drugs when someone has an AKI. That's not a good practice, right? Once they're out of AKI, then we can start those drugs because there's a lot of good research about spironolactone for heart failure patients. It's great, but when they're in AKI, it's not great. Okay, so if the K is 3 to 3.5, that's actually okay. With cardiac patients, you want it more than 3.5. But a renal patient, it's actually all right for someone's K to be on the low side because it gives you some little buffer, right, in case they do get more acute kidney injury or not. Okay. The only exception is if their MAG is also low. That's not great. You should make sure the MAG is corrected. All right. What is MAG for?
Makes everything work.
It's the key to the protein channels that make the protein channels actually open up and allow K to get on through into the bloodstream or not. All right, if you don't have MAG, then you're going to have low K because the K is just going to get lost in the urine, right? So we want to make sure the MAG is corrected. MAG is good, and then you can keep the K about 3 to 3.5. It just mentions about DIG toxicity, but not many people are on DIG nowadays, but still, if they are DIG toxic, you want to make sure they're not hypokalemic. That's going to cause to toxic levels. Okay, so doing all of our labs that we know about, right, and make sure we're looking for underlying causes. Look, we talked about, spend a lot of detail on if they have rhabdo, do they have glomerulonephritis, do they have a pre-renal failure, a shock state. We got to fix those things, and trending the labs can help us know if their kidney failure is getting better or worse. So get a MAP, that's great, right? MAP greater than 65. What happens if the kidneys don't get 65? They get upset, they start releasing the RAS system, the ADH will fire off eventually, SNS will fire off. So we want the MAP appropriate, which is 65, and 75 is for who? Those with chronic hypertension, because their kidneys, their renal arteries here are pretty sclerosed, I should have read, are really sclerosed there, right? It's because of all the hypertension over time, they got decreased flow to their kidneys. So we want to make sure they have good, adequate flow to their kidneys, right? Make sure the MAP is at a target of at least 75 for long-standing hypertension. And then euvolemia. So euvolemia, we kind of mentioned that by day 3, day 4, they should be even on their fluid balance, right? Their eyes and nose should be corrected. And if we don't, then that's going to cause more damage, right? It's going to cause more issues. And one of the issues is that the fluid can just start getting, we talked about intraabdominal hypertension, where the fluid goes in the belly, compresses the kidneys, but there's actually this membrane around the kidneys that it's called intracapsular edema. So all the fluid starts compressing there as well, causing a destruction of the kidneys, right? Or an AKI in of itself. So make sure the fluid balance is correct. And then if we do give fluids, right, make sure that, so we got balanced eyes and nose, right? If the best fluid for, if you have to guess, you're going to Vegas, you're going to say what? You're going to say lactated ringers. That's going to be the go-to agent for someone that needs fluids, right? So LR is going to be your go-to agent. Normal saline is only given if someone actually needs hyperkalemic acidosis, hyperkalemic metabolic acidosis, or if someone needs to have an AKI. Like if you want to say, you know what, your kidneys are hurt right now, I'm going to give you normal saline. All right, that's going to make their AKI even worse. So otherwise, it's going to be either LR or bicarb drip. Okay, and as I mentioned, if you see your patient on bicarb drip, it usually means they have an AKI and they're trying to prevent the AKI from getting worse and trying to prevent them from getting or requiring renal replacement therapy or hemodialysis. Okay, so if someone's acidotic, well, that makes sense. Bicarb is going to fix that, right? And it needs to be a drip. Giving pushes, as we'll talk about, is not appropriate. Okay, and then LR is for those patients that are not quite acidotic, but they need fluids, right? And of course, in the ICU, it's going to be someone. It's going to be pretty uncommon, but it's going to be someone who has like a GI bleed, someone who has a lot of nausea, vomiting, diarrhea. That's someone that might need to have a fluid resuscitation. Okay. And then not abnormal saline, as we talked about many times. I'll talk about again, right? It's going to cause, if you have a metabolic alkalosis, you can argue to give it, right? Because it's going to acidify the blood. So that might help, but it's also going to worsen the kidney function. And we have other diuretics that we can give to acidify the blood. Which diuretic was that? Acetazolamide, right? Acetazolamide acidifies the blood, right? So that's a better option than giving normal saline. Okay, volume overload, as we mentioned, is going to cause more issues, increases intracapsular edema, increases CVP, and that's going to increase the renal afterload. So the kidneys get fluid, and they're trying to dump the fluid out that they just got. And if they can't, they're going to get less fluid in the future, and they get less blood flow, and that's going to lead to worsening outcomes, right? And then diuretics are a good idea, All right, to maintain euvolemia, that's what we're kind of doing on that day 2, day 3, day 4, to get them net neutral, to get them even on their fluid balance. We're giving them diuretics to get rid of potassium because we know they're at risk for hyperkalemia. So we give, furosemide and thiazide. Does that start with CEAT? Well, thiazide is a T, right? No. What is the T in CEAT? That analogy, that mnemonic? Something weird you never give, right? Triamterene, right? So yeah, so that you're comfortable, right? So it's not triamterene, it's not amiloride, it's not spironolactone or Milrinone. So then these guys are going to waste potassium, right? They're actually causing what's called kaliuresis. So kaliuresis is where you're uricine K. Okay, so furosemide is usually our go-to agent, and then after that we're going to add on thiazide. So it's like 2 K wasting diuretics to get their fluid down, right? The danger with getting rid of all that potassium is we know K and hydrogen, they switch teams all the time. They affect our acid-base imbalance. So if you get rid of too much potassium, you could cause what?
Give too much potassium.
Sorry, if you give too many K wasted diuretics. You give too many diuretics, that causes what? Causes a metabolic alkalosis. It's technically called a contraction alkalosis. Because yes, you're getting rid of potassium, the bicarb is going to go up, and then you're also making it concentrated. So now bicarb is really high, right? So to fix that, like we talked about, you give acetazolamide. Okay, and then there's the argument about LR, and we'll talk about this more in detail. But when we talk about LR versus NS, but there's arguments like, oh, you can't give lactated ringers because it's lactate. That's going to make them more acidotic, right? That's completely false. Doesn't make any sense. It has sodium lactate, not lactic acid, in it, right? And they're saying, oh, doesn't it cause hyperkalemia? It has potassium in the ingredients. I see it. It's right there. It's 4 MEQs. But my pH's K is 4.2. I don't want to add 4 to that. That's not how it works, right? So you're adding a dilute 4 MEQs per 1 liter, right? It's not 4 MEQs that you're just like giving like a K rider to the patient, right? It's 4 MEQs per 1 liter. The analogy I gave you was the coffee ice, right? So you have an iced coffee and you're adding ice to it, right? The ice is going to dilute your coffee. If your ice has 4 little tiny parts of coffee in it, will it dilute? Will it make your potassium go up? Not really, because all that water is going to add more volume first to dilute it before that potassium even contributes. Okay, so we want to make sure that we are dispelling the rumors. Right? There's very few reasons why you cannot give LR. There's argument like TBIs and such, but we found out that normal setting is actually more harmful in TBIs compared to other fluids. Okay, and we've talked a lot about the fluid balance and what happens if we have all kinds of organ dysfunction if we give too much fluid. So we always have to be alert to the I's and O's. That doesn't lie because we're really good number keepers. We know that's how much we're giving the patient, and we're not even counting flushes and TKOs and other random stuff that might be going on with the patient, right? So all of this can cause edema and intra-abdominal pressure, causing a lot of things that cause AKI with fluid accumulation. So we want to avoid fluid overload is the kind of the end of the story.